Good afternoon, everyone. I'll be presenting the abstract on the trombone trial that is testing radical prostatectomy in men with prostate cancer and oligo-metastases to the bone. So basically, the trial was started depending on the seed and soil hypothesis and the self-seeding phenomenon, which represents that if the receptive microenvironment is available, the malignant cells can proliferate well. So keeping this in mind, two trials conducted first the role of RT. The Stampede trial studied in a subgroup analysis the role of RT in the oligometastatic prostate cancer group, and they found that there was a relative survival advantage of around 32% at 3 years. But when this was extrapolated on the high burden disease group, it did not show any benefit. The role of RT then further was studied by the HORAD trial, and it did not support or show any benefit even in the low risk metastatic group. So there was an urgent unmet need as per the authors to study the role of surgery or the local radical treatment in this particular subgroup, and there was no RCT conducted till then. The aim and objectives of the study was to study the feasibility of recruiting and randomizing men, to understand the recruitment challenges and inform the optimal recruitment strategies, and to collect the quality of life and the early oncological, safety, and the functional outcomes in these men. It was a prospective randomized controlled feasibility trial. 50 patients was considered to be the ideal sample size, because they found that an average of 1 to 2 patients were recruited every month in these centers, and over thinking that only 50% would be eligible and included in the group, this sample size was decided. It was a period of over 18 months after an initial 3-month setup period. Randomization was stratified on a 1-to-1 basis ratio. It was a non-blinded study, and only descriptive statistics were used to inform a future possible full trial. They used a particularly new aspect, that is a quantity recruitment intervention, where it was conducted in the 2 phases. I'll describe regarding it in the later part of my talk. The inclusion criteria were all the men with oligometastatic prostate cancer, that is 1 to 3 skeletal lesions that were diagnosed on bone imaging, no visceral mets, age less than 75 years, locally resectable tumors T1 to T3, good performance status 0 to 1 ECOG, and suitable for radical prostatectomy within 3 months of starting the SOC. The exclusion criteria included contraindications to radical prostatectomy, presence of visceral mets, prior radiation therapy, or current involvement in any other interventional research. The intervention arm comprised of the group undergoing robot-assisted radical prostatectomy and EPLND, and all the patients in both the group received the standard of care, that is ADT and docetaxel. Preoperative parameters, intraoperative parameters, and postoperative parameters were recorded until 6 months postoperatively. So the primary outcome of this feasibility study was to study whether randomization and proper recruitment would be feasible or not. So out of the total screened patients, only 40% were eligible, and out of them only 71% were randomized. So the QRI is basically conducted in 2 phases. In the first phase, they realized in the first 3 months that there was no proper recruitment, and they realized that the factors were that the inability to identify eligible patients, lack of clinical equipoise, and inability to receive docetaxel chemotherapy preoperatively. So in the first phase, what these people did was to study the audio recordings of the nurses, the oncologists, and the recruiters. They studied the logbooks, monthly data logbooks, and they assessed the study protocol as well. They found out the loopholes, held a meeting with the chief investigator and the tumor management group. They found out the solutions to it, and in the next phase, they found out that the randomization rate was higher, although the eligible patients were fewer than expected. The secondary outcomes were the quality of life assessment at baseline and 3 months, perioperative outcomes, the early oncological data, and the early functional data at 1, 3, and 6 months. They found that in the intervention arm as well, even after they underwent surgery in this particular setting, the functional and the oncological outcomes were similar to what the surgery was performed in the localized group, as shown in other studies. The limitations were the heterogeneity and the lack of consistency in the imaging modalities, because few centers use the PSMA, few other cross-sectional imaging modalities. But however, due to this heterogeneity, it increases the study's generalizability and application of the results across all centers. The quality of life impact was measured by a generic tool, and the role of SBRT was not examined, but the authors are planning to examine it in the full trial. Whether this is a landmark trial or not is still to be decided, because it was the world's first randomized clinical trial examining the feasibility of RP in the OMPC setting. It was not only feasible but also safe. The confidence of the surgeons operating this particular group has also increased, which will definitely have an impact in the future definitive trial. Thank you.